This explainer is based on Post-Concussion Dizziness, a vestibular physician's deep review of mechanism, diagnosis, and management, published by Australian Dizziness Clinics. We're jumping straight into part 4 of their intensive 6-part series today. So if you're a vestibular physician, a neuro-otologist, or an advanced trainee, get ready. We're going to break down the exact evidence-based algorithm used to untangle literally one of the most diagnostically complex presentations in our entire specialty. So let's get into it. Diagnosis, red flags, the VFT battery, and the algorithm. You know, diagnosis is a highly disciplined sort, right? In this explainer, we're applying the red flag gate, that mandatory positional screen, VOMS, and the formal test battery that assigns the exact vestibular subtype to your patient.
We've got a really clear clinical algorithm to follow. We'll be looking at the red flag gate, mandatory positional screening, VOMS and provocation, the VFT battery, patterns, and finally, diagnosing in parallel.
Section 1. The red flag gate. Safety first, always. Look, before we even think about doing any complex vestibular testing, we absolutely have to use a structured history. We need to fix the mechanism of the injury, the timeline, and explicitly screen for red flags. This is our non-negotiable safety check, guys. New focal neurology? Progressive headaches? What about gait ataxia that's just totally disproportionate to the vertigo they're reporting? Or new, sudden sensor and neural hearing loss? Or direction-changing nystagmus in primary gaze? All of these mandate immediate, urgent action. No exceptions. These are hard stops that require an emergency CT or an MRI with susceptibility-weighted imaging. We have to rule out posterior fossa pathology, temporal bone fractures, or brainstem injury right off the bat.
Now, a distinctly interesting red flag here is skew deviation. You know that vertical ocular misalignment you're actively looking for on alternate cover testing? It's a HINTS positive finding, and it points directly to a central structural lesion right within the brainstem otolithic pathways. And that demands an immediate MRI. You literally do not pass go until central structural pathology is definitively ruled out.
All right, moving to step 2, mandatory positional screening.
Okay, so once we've safely passed that red flag gate, positional screening at the bedside becomes absolutely non-negotiable. A bilateral Dix-Hallpike and a supine roll test are mandatory for every single post-concussive patient. You might be wondering, why every single one? Well, because coexisting traumatic BPPV is present in a staggering 20 to 30% of these cases. That's huge! The mechanical acceleration-deceleration forces of the injury literally degrade the adhesive matrix holding the otoconia to the utricular macula. It basically dumps calcium carbonate crystals directly into the semicircular canals.
And listen, you absolutely cannot skip the supine roll test. A negative Dix-Hallpike does not exclude BPV after head trauma. Actually, horizontal canal and anterior canal variants are significantly overrepresented in traumatic injuries when you compare them to idiopathic cases. Plus, you have to anticipate that traumatic BPPV often needs multiple treatment sessions, and it carries a really elevated recurrence rate too. We're talking about 40% within 2 years, so be ready for that.
Moving right along to step 3. VOMS and provocation. So still at the bedside, we need to quantify oculomotor and vestibulo-ocular dysfunction, and we do that using the VOMS provocation meter. This is exactly where we capture the functional impact of the injury on visual and spatial processing. Here's the key takeaway. If you see any domain score rise of 2 or more out of 10 on the provocation visual analog scale, that flags profound clinical significance. That simple jump of just 2 points, it reliably predicts a prolonged recovery trajectory for your patient. It's an incredibly powerful piece of prognostic data, and you can gather it in just a few minutes, way before the patient even leaves the exam room.
Okay, step 4, the VFT battery patterns.
Once our bedside screening is wrapped up, we head into the lab. Because the Advanced Physician's Toolkit extends way beyond clinical bedside maneuvers, right? This is where we map the precise anatomical location of the deficit. We rely on VHIT to quantify high-frequency VOR gain and identify any covert corrective saccades. Then, we use cervical and ocular VMs to map the otoliths, specifically the saccular and utricular nerves. We bring in bithermal calorics for low-frequency unilateral canal paresis. And finally, we use computerized dynamic posturography. This characterizes the evolving visual dependence we so often see in conditions like PPPD.
So from all of this comprehensive testing, your ultimate goal in the lab is to objectively sort the patient. You're looking to place them into one of 3 definitive patterns: a peripheral pattern, a central pattern, or an entirely normal battery. Let's compare the mechanics for a second.
A peripheral labyrinthine concussion, for instance, shows reduced VHIT gain with covert saccades combined with reduced VEMPs and asymmetric calorics. That tells us we're looking at a structural injury to the end organ. Conversely, think about a central diffuse axonal injury, or DAI. That presents with a perfectly normal VHIT, simply because the VOR circuitry below the injury level is still completely intact. However, they're going to have impaired smooth pursuit and bidirectional saccades. This specific pattern, a normal VHIT, paired with an abnormal Hintz exam, is that classic central fingerprint that absolutely demands further MRI investigation.
But wait, what if everything is completely normal? Well, it is absolutely vital to remember that a normal VFT battery is not a dead end. Not at all. Rather, it actively points your diagnosis toward PPPD, post-traumatic vestibular migraine, or autonomic dysregulation. You see, after an acute vestibular precipitant like a concussion, the brain dynamically alters how it weights sensory inputs. This often leads to visual dependency and a major hypersensitivity to motion. That right there is PPPD. The structural tests are normal, sure, but the perceptual networks are maladaptively recalibrated.
Finally, step 5, diagnosing in parallel. With these precise test results in hand, we reach the final stage of our algorithm. This comprehensive diagnostic pathway basically maps the entire flow. We go down from the red flags, through the positional screen, sorting the patterns via the VFT battery, and it culminates right here in step 3, designing the multidisciplinary management plan based on parallel diagnosis. Honestly, this is where true clinical mastery comes into play.
The absolutely crucial takeaway here is that diagnosis is parallel, it's not exclusive. Did you know up to 40% of post-concussive PPPD patients have coexisting traumatic BPPV, a partial labyrinthine concussion, or post-traumatic vestibular migraine? These conditions overlap dynamically. It's like a giant puzzle. You have to document every single positive finding and treat these concurrent subtypes together. Because think about it, if you only treat the PPPD while leaving a mechanical BPPV unaddressed, you're leaving the perpetuating precipitant completely intact. And if you do that, the patient simply will not fully recover. So, having mapped out the red flags, executed the mandatory positional screens, and categorized our 3-pattern VFT results, we're left with the ultimate clinical puzzle. How do we actually apply our treatments? How do we tailor the rehabilitation, the repositioning, and the pharmacotherapy to this complex, overlapping matrix of symptoms?
Well, in the next installment, part 5 of the Source series, we transition from diagnosis to actual treatment. We'll be covering repositioning, subsymptom threshold exercise, and that combined approach to PPPD and migraine. This has been an Australian Dizziness Clinics vestibular-physician review. Visit AustralianDizzinessClinics.com for the full literature review and clinical cheat sheet. Which of these diagnostic patterns is going to change your clinical practice tomorrow? Until next time, stay focused and keep learning.